Dr. James Giordano is an orthopedic surgeon with an office in Ridgewood and Mahwah. He completed his medical degree from Temple University, a residency in orthopedic surgery from St. Luke's Roosevelt Hospital, and a fellowship in sports medicine from the University of Southern California, Keck School of Medicine. Dr. Giordano is board certified in orthopedic surgery. And now I'll pass it over to you, Dr. Giordano. Thank you for joining us.
Thanks a lot. All right, so I guess I'll start off. So we're talking about innovations in knee pain and just how to treat knees in general. So I'll kind of go through a bunch of those things today. Thanks. I mean, that's basically a little bit about myself. I went to Notre Dame and then Temple for medical school. Did my training at what was Mount Sinai, but St. Luke's Roosevelt. My fellowship, which was additional training in sports medicine, orthopedic surgery. And so I'm now licensed in New Jersey and operate primarily out of Valley Hospital, but also at Valley Surgery Center, Luckow over in Paramus, and Surgicare in Ridgewood. So that's kind of about myself. In general, I'll start, what is an orthopedic surgeon? So it's not toes, it's not the mouth. In general, orthopedic surgeons are specialists in surgery and also non-surgical issues involving the spine, the joints, the muscles, the ligaments, tendons in the body. So that's kind of broadly what we do. And then there's a number of different subspecialties. So there's spine, joint replacement, hand surgery, foot and ankle, pediatric surgery, so children, trauma surgery, sports medicine. And I primarily do sports medicine, although I do trauma as well. So this is our group. We have 10 physicians, and we do, between the 10 of us, we're very diverse. So we have some sports medicine doctors, spine surgery, joint surgery, hand, foot and ankle. So, if you have any issues that come up, this is our group. This is my practice. So I do spend time in the office, also in surgery, covering the emergency room at Valley Hospital. And that's me. So what kind of surgery do I personally do? So sports medicine, so shoulder, hip, knee arthroscopy. Arthroscopy is basically using a camera, so it's not, so it's more minimally invasive than big open surgery, and that includes fixing the rotator cuff, which are the sort of tendons and muscles in the shoulder replacements, ACL, kind of get into what that is, and then some meniscus and cartilage surgery, as well as broken bones. So today's focus really, again, is on the knee. So I'll start sort of with non-surgical ways, prevention, and then some different treatment options that include surgery and non-operative care again. So prevention, I think it's important to start with this before coming to your orthopedic surgeon. I think these are the different ways to sort of exercise and aerobic conditioning, strength and endurance, flexibility, balance, and I'll kind of go into each one of those things in general. So aerobic conditioning can be walking, particularly speed walking, running, biking, swimming, skiing, and so these are very important. Strength and endurance can enhance your cardiovascular system, also increase flexibility, strengthens your bones, obviously strengthens muscles, helps with endurance, and maintains body fat within acceptable limits. And the last one's important. Sometimes it's obvious, but maintaining body fat really helps with knee pain. As your body weight goes down, knee pain also goes down. So all of this is important. Strength and endurance, typically it's good to do it every other day. Even just 20-30 minutes is okay, or good. Resting for short periods of time, and then you really want to exercise to fatigue your muscles. Flexibility helps you perform the activities you want to perform better, helps you avoid injuries. The two main components involve warming up and stretching. Warming up can be marching, can be walking in place, some things like jumping jacks. You're really trying to mimic the sport that you're about to do with a little lower intensity. Stretching. The key to stretching is you're not really trying to stretch through pain. You want to hold a stretch for 30 seconds, relax into the stretch, breathe deeply and slowly, avoid sort of a bouncing, jerking type motion. And really that first point is you don't want to feel pain during any of your exercise. It's really not no pain, no gain. It's really listen to your body and don't push it. Balance prevents falls and injuries, helps maintain independence. Really want to work on your cores and lower body. Exercises like yoga, Pilates, and really boxing has taken off a lot recently. for assistance with balance. And then really just cross training, it's important to sort of incorporate everything. So incorporate aerobic conditioning, strength training, flexibility. You want a well-rounded fitness program. It prevents you from getting bored, hitting your plateau, preventing overuse injuries from doing one specific sport. I mean, recently, a lot of especially teenagers are doing the same sport all year long, and that can lead to these overuse things. So it's really important to try to be well-rounded. And then sometimes injuries occur and you need to see your orthopedist, and I'll kind of go into some of those things. These are the specific things that you can look for to say, I need to go see my orthopedist, or so a visible deformity. If you fall and you notice something doesn't look right, typically that's the reason to come see us. Antalgic gait means pain when you're walking, particularly if it's new. Joint malalignment. Ecchymosis means significant bruising. Swelling. Effusion is basically fluid in your joint, your knee joint. So that's more concerning. Loss of motion, if all of a sudden you become stiff or you can't bend your knee. Painful crepitus, like all of a sudden if it starts like a painful cracking noise. If your knee feels loose, particularly over the joint line, if you notice catching or specific pain. And then fevers can be a sign of infection or significant pain at night, especially if it's disrupting your sleep. And then, for example, if you go to the emergency room and you have a specific diagnosis, a knee dislocation is very severe. A knee dislocation, if extensor disruption means you're unable to straighten your knee, certain fractures, a locked knee, again, if you can't bend your knee, septic, which means it's an infection, meniscus tears, I'll kind of go into that more in detail later, certain ligament tears, kneecap, which is a patella dislocation, arthritis, and significant pain. And then if you are in the office, X-ray is really the first way to sort of help diagnose the knee. So you want to start with that. It's good for a good global picture of your knee. Do I have a fracture? Is something broken? Is there a dislocation? Do I have arthritis? This is really inexpensive. And the way things have moved with healthcare, often in order to get further treatment, insurance companies want to see an X-ray first. So, and there really isn't a lot of radiation with an X-ray. So it's important to start with that. MRI. It's good for seeing ligaments, cartilage, bone, muscle. It's more detailed. There's multiple planes. Typically, there's 3 planes, as you can sort of see on the picture on the bottom right, but it's a very detailed picture of the knee. There are some user-dependent, reader-dependent things that sometimes come up on MRI, but in general, the radiologist reads it. We also take a look at it, so this is a good study, and it's more expensive. And then treatment options, sometimes as simple as splinting or bracing. Reasons to splint or brace your knee: if the knee's unstable, certain fractures or breaks, unable to extend the knee, severe pain, infection sometimes. But it's important to keep in mind that a lot of times bracing hasn't been proven to sort of alter the course of arthritis, so it's not really as important in an arthritis picture. Pain medication, these can be simple as Tylenol or other anti-inflammatories. We can prescribe anti-inflammatories in the office. Sometimes those are longer acting, more effective. Typically, you want to start with a lower dose to minimize side effects, and then increase the dose if needed. And really, you want to stay on anti-inflammatories, hopefully for a short course, so there's no side effects such as stomach irritation, those types of things. And narcotics or opioids are really, we try to avoid them as much as possible these days, especially if more knowledge of addiction and those types of issues come up. So really, you want to try to avoid opioids in most circumstances. And then over-the-counter supplements, herbal supplements, there's obviously a lot of money, I would say, with these products. So you have to be very careful with them. So glucosamine and chondroitin, although they're good in theory, glucosamine is basically a primary building block of cartilage. It supposedly can stimulate basically different factors that can help build cartilage, but there's really no evidence it works. And the same thing with chondroitin. It's found in trace amounts in cartilage. There's claims about it, but the studies that we've done really haven't shown that this alters the course of arthritis or is more effective than placebo. Other things we can do in the office: if the knee blows up with fluid and effusion, sometimes we can pull fluid out of the knee. This can be done for pain relief. Sometimes if the knee's blown up with fluid, it's hard to get a more accurate diagnosis, so this can also help us. It can aid with range of motion, so that's one other option in the office. Treatment options: physical therapy. I think physical therapy can also be very important. It can help with some of that range of motion, reduce your stiffness. Other strengthening exercises are important. Core strengthening, hip strengthening has also been found to be very important for knee-related pain. So I think that's important in many circumstances. Injections, I'll kind of go into some of the different types of injections. The tried and true is cortisone, corticosteroids, hyaluronic acid. I'll get into that. And then as we talk about more innovation in orthopedics, I'll get into platelet-rich plasma, which is PRP, and then a little bit about stem cells. So corticosteroids, it's more for pain if there's mechanical symptoms such as something is catching in my knee. It doesn't really help with that mechanical type catching, locking, buckling pain. So corticosteroids can be effective. Really want to avoid them in children or adolescents, obviously done by a physician, and you want to limit the number. And I'll kind of go into some of the reasons why you don't want to do too many cortisone injections in a second. And this is it. So the lower grade effects, localized loss of subcutaneous fat. I mean, it's usually pretty minimal, especially in the knee joint. You don't really experience that. Same with depigmentation of skin. The main risk is in a diabetic. It can make your blood sugars go up. So you have to be careful, especially in a brittle diabetic. You don't want to inject cortisone and have your A1C, your blood sugars go out of whack. So other things, tendinitis, you shouldn't inject cortisone into a tendon. It can cause it to rupture, affect the ligaments. And in theory, it can cause bacteria. This is rare, but it lowers immune response. So you have to be cautious about that as well. I'll get into viscosupplementation, which is also known as rooster comb. It was initially taken out of the back of a rooster. More recently, it's been derived in the lab. It's also known as gel, hyaluronic acid. So as arthritis progresses, the concentration of hyaluronic acid decreases. And so the injection of gel hyaluronic acid is to restore this decline. It can be done as a one-time injection, or sometimes it's done 3, 4, 5 times. And then sort of a newer innovation, we'll call it. So PRP, platelet-rich plasma. I'll get into this more just because not everyone knows about this. They're components of your blood. So to do the injection, we actually draw blood, plasma, red blood cells, white blood cells, and platelets. And so the PRP comes from the plasma. So really it's the plasma of the blood, and it's the part that has more platelets than the baseline amount. And how does this work? Platelets form blood clots. And so we're really trying to minimize the inflammation, skip that component, and then go to the proliferation, the regeneration. So using the active proteins in the platelet-rich plasma to help with regeneration from arthritis or other ligament issues that come up. And so really today I'm going to talk about the knee, but there's other indications for it as well. So again, some of the side effects, cortisone, it can soften the cartilage, weaken tendons. In theory, you can have disease of bone from that. Gel injections, sometimes there's a risk of allergic reaction. It's very rare, but it can happen. And then PRP, there's not really any side effects. Evidence, so there's better studies. So some of the things I'm going to talk about today, and I was asked to talk about stem cells, is the evidence really doesn't back it. And so with PRP, we've had a mix of studies showing that it works longer term than cortisone and gel. So again, a lot of these things, I don't want to suggest it until the literature really backs it. And so it's really getting there with the platelet, with the PRP. And then stem cells, theoretically, this is often taken from bone marrow. So putting a large gauge needle into the bone marrow. It's safe to do this, but it's expensive. There's pain from the harvest site. Often it's done under general anesthesia, so there's risk of anesthesia. And the stem cell literature isn't really there yet. So there aren't good studies that say stem cells work and treat osteoarthritis of the knee effectively. And so definitely cautious to recommend this until more literature comes out. Then we get into surgical options. Meniscus tears. So meniscus tears are very common, so I'll just touch on that to start. So it helps the knee joint basically transition weight, gliding. Often they're twisting injuries that can be during contact sports. Many people come into meniscus tears and don't have a specific reason for a meniscus tear. It also occurs often with the progression of arthritis. So so what are the symptoms? Knee pain, knee buckling or giving way, locking episodes, clicking, swelling. So those are some of the symptoms to look out for. And then how do we treat meniscus tears? Often treated conservatively, treated without surgery, but arthroscopy I sort of brushed on before. So basically arthroscopy is a surgical procedure using a camera, and that's not the perfect picture up in the top right, but basically there's two tiny focals. They're typically about the size of a pinky tip, and they help get a better picture of the knee and the meniscus. And so by actually putting the camera in the knee and using certain instruments, you can check it, probe it, and see where it's torn, and then use these small instruments to clean that tear up. So I'll kind of show you some pictures in general. So what a meniscectomy is basically, if you look at the top right, there's some shredded, there's some tearing, and then the bottom left picture, there's a big flap of meniscus. And so obviously that's abrasive, it's painful. And then what we do is we use these instruments to sort of make a nice smooth surface like shown in the bottom right. So you're trying to avoid any big flaps. It's like having a rock in your shoe, and you sort of want to clean that down and make sure there's nothing abrasive in there. And then the goal of meniscus surgery is to leave whatever viable meniscus is functional. So the meniscus helps prevent arthritis, helps protect your knee. And so really we're trying not to cut out any functional meniscus. And so often I get asked that question, is this going to cause my arthritis to progress? And really we're trying to be cautious so that does not happen. A meniscectomy, it's outpatient surgery, in and out the same day. It's pretty quick. The surgical time is usually under a half hour, but an hour overall. To put weight on it right away. Usually we give you crutches or a cane for the day of surgery, but in general, put full weight on it, avoid anything strenuous. It's a pretty quick overall recovery. People are typically doing pretty well by 6 weeks, full recovery by 3 months, and then good overall results when done appropriately. So when done for a meniscus tear, good results. Sometimes the indications are stretched a bit, and really, want to avoid this surgery for bad arthritis. Newer things we're doing. So historically, the meniscus was cut out. In the right circumstance, we can repair it. As you can see on the top right, basically sutures are put into the meniscus. It's typically done for younger patients. There are times when the meniscus is detached, where the root is basically at the attachment in the back of the knee. And sometimes we repair that to preserve the knee. But this is a much more significant recovery. It's typically 4, 5, 6 months. Can't put weight on it right away. There's more stiffness. So you only want to do this repair when it's the right circumstance. And many times it's not indicated, as, for example, like a shredded meniscus, you can't repair it. So very case dependent. And I tried to show the bottom right of there are these systems that help repair it. But the goal is to preserve the longevity of the knee. And if we're able to repair the meniscus, it helps to do that. One of the newer things we're doing is a meniscus transplant. There's not a lot of times when this is indicated, but typically a younger patient without any meniscus remaining after a bad tear, sometimes we can actually take a meniscus from someone who's passed away and put a new meniscus in. But this is a long, challenging recovery as well. I'm going to talk about ACLs. They're also fairly common and a big part of my practice. So often a non-contact injury, but often can be with direct blows to the knee, many planting type injuries, landed on extended knee, making an abrupt stop. So these are very common injuries overall. So not everyone needs an ACL reconstruction. These are more common for people who are active, who like pivoting sports. Things like tennis, skiing, now pickleball are challenging without an ACL just because the knee tends to give out or buckle with change of direction. One of the newer things I'm doing is basically taking the quadriceps tendon, so the tendon that connects the quadriceps muscle in your thigh to your patella to your kneecap, and basically taking the central portion, basically the central centimeter, the sliver of that tendon, and then making a new ACL. And so our studies have really progressed as far as how well this works. There's not a lot of donor site morbidity by taking a tendon graft, as opposed to historically we took bone patella bone, which is a very good graft and often used. But typically the quadriceps early on have less pain, and they have very good retear rates. So this is something newer that I'm doing that's being done that have good studies. And then in the media, in the news, ACL repairs, and then something called a bridge-enhanced ACL reconstruction is something that's also being done. As far as an ACL repair, and it's called a bare implant, the literature really hasn't gotten there. ACL reconstructions by using sort of the tried and true way, have a lot really good outcomes. And so, I get asked about these repairs or this newer system, and it's hard to suggest it until we have better literature proving that it actually works well. And that's really not there yet. Cartilage restoration, there are other ways. Arthritis is sort of overall the degradation or the wearing out of the cartilage, the cushion in your knee. And so there are ways when there's more smaller isolated lesions that we can address that without actually doing a full knee replacement. And these are some of the things I do, like a microfracture where you're basically drilling little holes in the bone and allowing some stem cells to come in and repair that cartilage. Something called a MACI, or matrix-induced autologous chondrocyte implantation, which basically means we grow cartilage in the lab and put that scaffold in your knee. It's a 2-stage surgery. And there's only specific indications where these things are appropriate. So an allograft implantation means taking cartilage and bone from someone who's passed away and putting it in your knee. But again, the indications are specific. So it's not as if someone has fulminant arthritis and we can do these procedures in many cases. And then for severe arthritis, I mean, this is a knee x-ray on the left, which looks normal, and the right is basically bone-on-bone knee arthritis. And common, and that's another issue, and so I'll kind of gently touch on that. So knee arthroplasty, either a partial knee replacement, which you can see in that picture on the left, on the left side, or a full knee replacement, which is on the right side. There's been progress as far as we use replacements to do that. Within my group, I'm not the one doing the knee replacements. Dr. Delfico, Dr. Dizdarovich, and Dr. Pizzaro are doing them. So if you do have that issue, you can see them. So key points, I think prevention is really important. Warm up, stretch, gradually increase your intensity and duration. Be prepared to take a break, especially if you're having knee pain. Cross-train, be broad in your activities. And then when it's appropriate, come see help. And there are many things we can offer. There are newer things on the horizon, but many things are tried and true. So, and that's Dr. Zarevich and I and our kids, taking them skiing. So trying to exercise. That's it.
Great. Thanks, Dr. Giordano, for that presentation. And so we do have quite a few questions that came in. And if you have any questions at home, please feel free to send them into the Q&A portal there at the bottom of your Zoom screen. So question number 1, Dr. Giordano, you mentioned exercise to fatigue your muscles. What does that mean?
Basically, you want to exercise so you feel the fatigue of working out. So if you're doing weight training, it shouldn't be just light, rapid motions where you don't really feel any burn, any exercise in your muscle groups. So you're really trying to feel the resistance in your muscles when you're exercising. So that's what I would say. Okay.
And then can X-rays show arthritis?
Yes, they can. So that's the best way of that's the best way of getting a good global picture of your knee. So that's typically why we start with an X-ray. Many times we don't need an MRI. I mean, X-ray is often enough of a study without an MRI to see arthritis. So you can see whether you have no arthritis, mild, or more advanced, and sort of in the replacement realm of arthritis.
Okay. If the meniscus is mostly devoid of blood supply, why does pain from a torn meniscus, which is seen on MRI, often go away without surgery?
Well, there are other pain generators in the knee, and so sometimes a meniscus tear doesn't always hurt. If the more of like a flap can be abrasive, and that often hurts, but a small tear sometimes just becomes asymptomatic. And when you tear your meniscus, that process hurts, causes inflammation, and then over time with therapy, we don't know why exactly, but some meniscus tears just don't hurt.
Okay. And then what would cause knee clicking several years after a meniscus repair?
There could be a number of reasons. Well, not every meniscus. If we're talking about a repair where the meniscus was sutured, it doesn't always heal. As far as the last question, there's not great blood supply to the meniscus. And so in a repair situation where the meniscus was actually sutured, sometimes it doesn't always heal. And then if someone did have like a clean out type surgery, there can be a re-tear, there can be scar tissue. Sometimes clean out surgery was done when there's arthritis, so there can be some cartilage irritation that can cause clicking. There's a lot of reasons to have clicking in the knee.
Okay. Couple questions about PRP. Does Can PRP help with arthritis? And kind of like a backup question, another follow-up question is, do you recommend PRP to your patients?
I do. The problem with PRP, so that's what this, some of the studies have been showing that PRP is effective for arthritis, especially compared to cortisone and gel. Long term, the problem with PRP is it's not covered by insurance, so it can be expensive. And so I only recommend it in the right circumstance. Usually, I say start with a cortisone injection because that's covered. Um, Often, cortisone I think often is very effective, especially for shorter durations of pain. If that isn't effective, or if there's another option, maybe try the gel injection. And if that isn't effective, maybe try the PRP. But it's not covered. So hopefully in the future, the insurance companies sort of catch on to the literature and start paying for it. I think that'd be really be great if they did.
Got it. You mentioned bone disease as a side effect of cortisone shots. Can it increase possibility of osteoporosis in women?
Not an isolated injection. High doses of oral steroids, yes, but one isolated injection is not a whole lot of steroids. So not one injection.
Okay. And is there a limit to how many gel shots a person can receive, either in a year or in a lifetime?
Not not based on, there's no, besides the theoretical risk of allergic reaction, which again is very low, there's no downside to a gel injection. The problem is the insurance companies only pay for it twice a year. So realistically, there are some people who come in twice a year, get the gel injections, and that's very effective. And I think if that's effective and that sort of person doesn't want to go the replacement route, I think it's a really good option.
Okay. And then another question about gel shots. Gel shots or cortisone injections for bone-on-bone knee condition. What would you recommend?
The problem is with true bone-on-bone arthritis, they don't always work. So I usually start with a cortisone injection and then see how effective it is. I find overall, once it's bone on bone, many times the cortisone is more effective. But it's person dependent. Some people get better response out of either one. I think overall, once it's bone on bone, it's more challenging in general.
Okay. And then how can I determine if I need a total knee replacement or a meniscus? I'm sorry, I'm going to butcher that. Meniscectomy to repair a torn meniscus along with arthritis and pieces of cartilage.
I think that's a very challenging question that we have in general. When to do a clean out and when to do a replacement, especially if someone's sort of on the borderline. Definitely, if it's just isolated meniscus tear, the clean out is ideal. When it's bone on bone severe arthritis, replacement. But there are some middle pictures when it varies and it depends on age, and that's when we use X-ray and MRI together to sort of get a good picture along with other factors. But I think that's a time when imaging, story, there are other complexities that help decide, but that's often an issue overall in orthopedic surgery of clean out versus replacement type surgery.
Okay. And then what is the typical healing time for knee replacement, and is it recommended to do both knees at once?
Typically 4 to 6 months for replacement. Personally, I don't. Well, first of all, I will defer to my my joint replacement colleagues. But in general, I think that doing 2 knee replacements is really challenging. So I think having one stable knee, my suggestion is to do one at a time. I think 2 is really tough.
Okay, and then what is Synvisc knee injection?
Synvisc is hyaluronic acid or gel.
Okay. And is there anyone that is not a candidate for PRP? And I'm assuming this treatment is not supported by Medicare because you said that insurance doesn't really cover it. And then how long or often is the treatment? So the first part of the question is, who is not a candidate for PRP?
Oh, so because it's not covered, there are people who do multiple, but I would say start with one and see how it goes. I think that so in general, you need working platelets. So there are patients, for example, who have liver failure, cirrhosis, don't have good working platelets. I have to be off of things like aspirin, which inhibits or slows down the platelet function. So there are certain people, but for most people, there's really not a whole lot of a lot of people that are not able to do it.
Okay. And then what intensity is required post a knee replacement surgery in terms of physical therapy?
I think the most important thing is starting to gain the range of motion back. It's hard once that's not obtained to catch up when you have stiffness. So I think early on, just being diligent about obtaining a range of motion, and then after that, sort of working on the strengthening. So that component comes as well.
Okay. And then kind of another follow-up question to that. If you have a knee replacement, what can you expect recovery-wise? Are you able to walk right away, walk up the stairs, or do you need a walker for a while?
It it depends on overall activity level and age typically, but you can put full weight on it early on, definitely a walker, and then transition to a cane, and then hopefully off of a cane. Um, but it depends on a number of factors. Typically, start with a walker and then move up from there.
Okay. You already said that PRP is not covered, but do you believe in diet and fish oils like omega XL? How do you feel about them?
In general, good, but there's not great evidence. Same thing with the glucosamine, the chondroitin, those types of medications, turmeric. There's not great studies that back them as far as knee arthritis prevention or progression. So I have no issues with fish oils. I have no issues in general, glucosamine, chondroitin, or turmeric, but I just there's not great literature that shows that it alters the course of arthritis.
And do you know what the cost for stem cell injections is around?
Stem cells, thousands,
Yeah.
thousands, and that's why the cost is really prohibitive for stem cells, and the literature again is really not there. And there's other issues, general anesthesia.
Right.
You know, I'd be cautious. Cautious with stem cells.
Okay. And you wouldn't know how many would be needed. I guess it's probably case by case.
Exactly, case by
Yeah.
case. I mean,
Yep.
that's an answer.
Okay. And you mentioned treatment using blood platelets. Please repeat the process and name.
Well, the slang is PRP or platelet-rich plasma, but it's basically you come into the office and draw blood, and then there's a fancy machine that basically centrifuges that spins that down, and then we take the platelet-rich plasma out of the blood and then inject that into. It was initially done for a lot of elbow epicondylitis, but now the indications are expanding and often is done for knee arthritis.
And then how do you strengthen the tendons around the knees? Is there something that one can do at home to help strengthen them?
So, like things that are less stressful for the knee, like half squats can be very effective. Biking, low resistance biking, elliptical, swimming is great. If you don't have knee pain, I think walking, particularly speed walking or speed walking uphill, running. If you don't have knee pain, I think can be effective. But the problem is sometimes when people do have symptomatic knee arthritis, running can be challenging.
And then can a meniscus tear eventually heal without treatment?
It doesn't repair itself, but it can stop hurting. It can stop being painful.
Okay. And then can you please give more detail regarding knee replacement? Who would be a candidate for the surgery? And what is it? Well, we've already talked about recovery time, but like basically, who would be a candidate for the surgery?
Well, I think important thing is people see they have arthritis on their X-ray and think they may need a knee replacement. You don't really replace a knee based on X-rays. So having arthritis that's more severe, middle grade, bone on bone, and then failing those things that aren't replacement. So working on therapeutic exercise like physical therapy or low impact strengthening, like the bike, like the elliptical, not getting better with cortisone, with gel, those types of things, not getting better with anti-inflammatories, not being able to sleep. So having enough arthritis that it's indicated based on x-rays and sometimes MRI, and then failing to improve with non-surgical things first. And then really just deciding, I've tried these things, my quality of life is affected, the time is right for me, and then going for the knee replacement.
Okay. And then is Synvisc knee injection covered by insurance?
Typically, not always. Often you need to do a cortisone injection first. Many plans cover it, not all do.
Okay. And then how do you know when it's time for it says TKR. I've read 20% of patients that had TKR were not happy year after surgery. If true, why might that be?
Um, Not everyone is happy. That's correct. Overall, there are good outcomes. I think sometimes knee replacement's done maybe before someone's ready to do it. So in the circumstance where I have mild arthritis, I jumped into a knee replacement. I really shouldn't have done a knee replacement. I think that's sometimes it's done, and there are very good overall. We've made a lot of advancements. They're not perfect. In general, hip replacements have a better outcome, but knee replacements are not perfect, but overall good, very, very good outcomes.
Okay, and then do you have an approximate cost for PRP?
$950.
Okay. And then can small tears be treated with physical therapy?
Yes, not every surgery is not always indicated for a meniscus tear. It depends. Some tears are more mechanical, catches, my knee buckles, my knee locks. Then those are less likely to be treated well with physical therapy. If it's more just pain, often therapy, injections, anti-inflammatories, those types of things can calm it down, and then eventually it doesn't always hurt. So definitely having meniscus tear doesn't mean you have to have surgery. And again, many times we see meniscus tears and arthritis, and it doesn't mean you need to have surgery.
Okay. And then a swollen knee. Let's say you haven't hurt it, but you have a swollen knee. Could that be some sort of like meniscus tear or something that you just didn't realize you had?
Often it's something abrasive in the knee, whether it's a meniscus tear, whether it's arthritis. So those are often things we look at, but there are other things we look for that aren't arthritis or meniscus, or for example, like Lyme disease or an infection. So rheumatoid, like there are many reasons to have swelling in the knee, and that's why I was kind of bringing up, if your knee is blown up and with fluid, that's a time to come and see an orthopedist, because it's more complicated than just a simple it's from my meniscus tear. So if you've never been seen by an orthopedist and your knee's blown up with fluid, that's definitely time to come in.
Okay. And then is it true that you can never kneel again after a knee replacement?
No, but sometimes it hurts after knee replacement.
Yeah. And then so you had said so cortisone shots a year should not cause any side effects of any sort, because that's what you said. You said I think you said Medicare covers it, or insurance covers at least two.
I think in the right circumstances, in the right age group, again, children, adolescents really shouldn't be injected with cortisone. But if you have knee arthritis and you're not trying to do a knee replacement, and cortisone, when done, sporadically, cautiously, is very effective. And so sometimes it's villainized, but I think realistically doing periodic cortisone injections is okay, especially in the right person. I don't have bad diabetes, my knee acts up occasionally, so that's definitely an option.
Okay. And then are there things that can be done during surgery to help range of motion and better post-surgical outcomes?
With replacement,
That's what I'm assuming.
yeah. So there are, and there's deformities that happen with knee arthritis sometimes. So the process of replacing the knee can help that, especially when the bone is sort of changed as far as the alignment. Many times stiffness is just scar tissue that occurs after surgery. So it's very important, if you're going to do any of these surgeries, really, to sort of think to yourself, I'm going to dedicate myself to that therapy after surgery so I have a good outcome. So that's why it's important, particularly with a knee replacement, to do the exercise, do the physical therapy, so that you have a good outcome.
Okay. And then what can be done to prevent mild arthritis from progressing to severe arthritis?
The only thing that's really effective for preventing the progression of arthritis is based on weight. So, it's tough because when my knee hurts, it's hard to exercise. So I can't exercise, so I gain more weight. But really, knee arthritis progression is very dependent on weight.
Okay. And then do you recommend physical therapy before surgery? So I guess that means like prehabilitation.
Depends. Depends. It's situational. I think going into surgery with the most strength and the most range of motion is important. So my preference is, if someone comes in and they're planning on having a big surgery, go in, really try to prehab as much as possible. It doesn't mean you need physical therapy. I think getting on a bike, getting on an elliptical, working on some home exercises, I think that can be very important. Physical therapy, I think, is great too. The problem is sometimes people are limited as far as how much physical therapy the insurance will cover. So I'm cautious with that, because especially if you're having a big surgery, you sort of want to save your physical therapy for after surgery so that you don't run out of therapy. So also case by case, and I would say that the goal in general, whether it's through physical therapy or exercise, is to go in with good range of motion and as good strength as possible.
Okay. And then for older patients, who may have pre-existing conditions like Parkinson's or mild dementia, is it prohibitive to have knee replacement?
De- Very dependent on the stage. So um, very dependent on the stage, is what I would
Okay.
say.
Yeah.
Early mild dementia, and the same thing with Parkinson's. There are more complications with anesthesia with Parkinson's. It's easier to have falls. So certainly advanced Parkinson's, advanced dementia, no, but early is not a contraindication.
Okay. And then can you sit like crisscross applesauce after a knee replacement?
Hopefully, hopefully.
Yeah.
So deep bending, deep flexion can be tough. Not everyone gets all of the range of motion, which is important. And again, why it's important to have the right to do it under the right circumstances and really try to work on the range of motion so you can get that deep bending, the deep flexion after surgery.
Okay. And then any thoughts on CBD or THX?
Also, something I don't have an issue with. I think that there's not great evidence or literature that it works. I don't say not to do it, but I think that we need better studies in general to prove that it works. Um, and I'm a little skeptical that those will ever happen. I don't think there's ever gonna I don't think it's gonna prove that they're effective um, as much as sometimes people want them to be.
Right. And then what do you think about THC for pain?
Same thing.
Mhm.
Same thing. I think that often recently, more and more as marijuana products are legalized, I get asked about them. I think that there's not great proof that they help for pain control. I think that in general, that's hard to sort of recommend. I don't personally have a problem with it, but there's not great studies that prove that that works.
Okay. And then can you talk a little bit about chondromalacia patella?
So chondromalacia patella is basically early stage or is arthritis. So chondromalacia means the cartilage is worn down, um, and so many times it's in the front of the knee, under the kneecap, under the patella, and it's a challenging one. The most important thing for that is basically low impact strengthening. Build your quad strength up, build your hip strength up, build your core strength up, so that it's not symptomatic. Many people have chondromalacia patella at an early age, so often will go into people in their 30s will start to develop some chondromalacia of the patella. It's not it's not out of the question. So not everyone has chondromalacia, has pain. So it's really important to sort of work on those strengthening exercises to better support your knee so it doesn't hurt. And then also things I sort of broached on early in the topic. So stretching, I think, is important. Stretching your hamstrings and proven to help the pain in the front of your knees. So chondromalacia patella is a challenging one. The clean out surgeries aren't effective. There's partial replacements where you can replace under the kneecap. The outcomes aren't perfect on those either. So really a good physical therapy program, a good exercise program, sometimes injections, often injections or anti-inflammatories are really the focus of treatment and trying to work through it so that the pain just stops.
Okay. And somebody asked if there's going to be copies of the slides available. We're not going to be sending out the copies of the slides, but we are recording this event, so it will be posted on our website by early next week. So you can actually just chatted the website into the chat, so you can grab that from there, so you have it for next week. And then there's a few more questions here. Explain cause and cure of a Baker's Cinct.
Well, explain what
Um, cause
so
and cure.
often there's a meniscus or arthritis, and that sort of causes fluid to escape in the back of the knee and pool in the back of the knee. Inherently, it doesn't need to be addressed, especially if it's many times it's discovered incidentally or we pick it up on MRI and it doesn't always cause pain. So we really tried to avoid over treating it. Just having it's called a Baker's cyst or a popliteal cyst, again, doesn't need to be treated. Sometimes if they're big enough, we can actually put our physiatrist, our physical medicine doctor, Dr. Terranova, can sometimes put a needle in and pull some of that fluid out, especially if it's symptomatic. The challenge with that is that the artery and the nerve are really back there. So For small, bigger cysts, we really try to leave them alone. For really big ones, sometimes she'll put a needle in with the ultrasound machine and pull some of that fluid out.
Okay, and then is bowing of the knee an indication for total knee replacement?
No, pain should be the so as arthritis progresses, you can get bowing, knock kneed, those types of deformities, but just being bowed doesn't mean you need a knee replacement. So that can happen as the cartilage is worn down. Um, but really, I would try to do it for more for pain.
Okay, and then what causes a burning sensation of the knee at nighttime?
It can be from a meniscus or arthritis. Either of those things can do it most commonly.
Okay. And then are there inflammatories that can be used with CKD?
That's a challenging one. I would ask a nephrologist. I believe meloxicam has some uptake by the liver, but I really would talk to whoever is the nephrologist treating the person, the kidney doctor.
Okay. I'm just going through to see if there's anything else. Oh, what do you think of fruit extracts for your joints?
In general, I'd be a fan of it, but I think anti-inflammatory diets, fruit extracts, those types of things are a good idea in general. I don't have a specific one I'd recommend, but I think it would be along the same lines: anti-inflammatory diets, fruit extract, those types of things, vegetables, um, avoiding the ultra-processed foods. I think that's great, but in general, I'll say that.
Okay. And then I'm going to just do one more here. And this is going back to the chondral malacia patella. Can you repeat what low impact strengthening knee exercises there are for that?
Usually bike is the easiest one. Sometimes bike can cause, especially if the seat is a little bit further away, you go into a little bit less knee bending. So I think bike's great. I think elliptical, probably rowing. Sometimes when you go into really deep bending, I think rowing's tough on the knee. So I usually say more stick with the bike and the elliptical, and then water aerobics. Valley has a great pool. Lifetime Fitness is around there. That's great. YMCA. So I think depending on where you live, if you find that water aerobics or pool, those are the lowest stress on the joints. And so I think for condymation of the patella, that's what I'd recommend.
Okay. Just looking to see if I missed any real like big questions. We talked about the Synvisc. We talked about the knee clicking. I think we've answered a lot of the questions, a lot of the main questions that aren't too specific. So I want to thank you, Dr. Giordano, for taking the time tonight to present to us.